Thank you, Dr. Amol Pawar. It's always pleasure to come back to Daman, and thank you to the organizers, definitely Dr. Krunal and all his associates. Well, Dr. Amol has rightly told that to limit the use of antibiotics, two things we have to know: one, when to use it and when not to use it. Now, we frequently discuss in different fora when to use antibiotics. This session is mainly when not to use antibiotics, so that will go a long way in avoiding misuse of antibiotics. And as Dr. Suhas Prabhu was telling, he is a follower of the practice of explaining everything by cases, and I am a follower of Suhas Prabhu, so I will also stick to some interesting cases of infection mimics. So to start with, this is a 7-year-old boy who came with fever, cough, and on auscultation there was diffuse rhonchi. The routine count was 13,800 with neutrophil 50, and you can see the X-ray. There is definite opacity in the right lower zone of the chest. So a lateral X-ray was done, and in the lateral X-ray you can see there the two fissures. There is upward bowing of the major fissure and the minor fissure is depressed down. So there is a triangular opacity which definitely looks like a collapse consolidation or a pneumonia. So the initial diagnosis obvious that comes to our mind is a right-sided pneumonitis. But when we take the history, this child is a known asthmatic, is on anti-asthmatic medication for a long time, and still the child is having rhonchi. So what could it be? This is a condition of right middle lobe syndrome. It's relatively common in children with asthma, especially the chronic or recurrent right middle lobe atelectasis. And the typical chest X-ray we have seen and the lateral that we have seen, the triangular shadow that more or less confirms the diagnosis of right middle lobe syndrome. The child was not toxic, counts normal, so this child doesn't need to be treated for pneumonia, rather proper asthma management is what required. 10-year-old boy, recurrent pneumonia on left side, repeated bouts of high-grade fever, and each time the child was admitted, given antibiotics and dramatically recovered. You see the post-cardiac, there is a triangular shadow that is in the left lower zone of the chest. So approaching a recurrent pneumonia, the possibilities, it could be a collapse consolidation, it could be a CPAM, a sequestration, a diaphragmatic hernia. So we had the options of further investigations like USG chest, CT, angiography, bronchoscopy. So some investigations were done, but ultimately it was the CT chest and angiography which confirmed. You can see the descending aorta and the blood vessels going out. This is a pulmonary sequestration. It's a mass of abnormal non-functioning pulmonary tissue, no communication with the tracheobronchial tree, and the anomalous systemic artery was supplying, and usually occurs in the left lower lung, and the intralobar is much associated with recurrent infection. So this needs surgical removal, otherwise the infections will continue. Another 6-year-old boy, persistent cough, occasional breathlessness, chest X-ray, you can see a dense rounded radio-opaque shadow in the PA on the left upper zone. Often we call it a round pneumonia. It may be due to any organism. Round pneumonia is not specific for a particular organism. Pneumococcus, staph, they all may cause round pneumonia. But you see the lateral X-ray. It's in the posterior mediastinum. So that was some pointer. Now, gradually this child developed both lower limb weakness and upper motor neuron type of paralysis. So this is not pneumonia. This is a space occupying lesion in the upper lobe. This is probably a neuroblastoma. 13-year-old boy, intermittent bouts of cough since the last 6 months, occasional low-grade fever, poor weight gain, and no history of tuberculosis in the family. Routine investigation, hemoglobin 9, WBC 9,600, TST was 8 mm with 5 TU, sputum AFB was sent, which was eventually negative, and this was the chest X-ray. If you can see closely the X-ray, it's a diffuse miliary shadow. So ATT was started by the other hospital before referring to our hospital. The justification they told was the miliary shadow in the chest X-ray. There was low-grade fever, persistent cough and poor weight gain, and the tuberculin sensitivity test was borderline 8 millimeters. So this was the justification. The child initially showed some improvement, but persistent to have cough. Even after 2 days, the X-ray was repeated and there was no change. So some thought comes that what it could be. A CT was done. It was a diffuse, you can see patchy opacity, typical of the miliary shadow that we had in the chest X-ray. Bronchoalveolar lavage was obviously done and it was negative. Now, along with other investigations, just to cut the long story short, ultimately the lung biopsy was done and it showed thyroid tissue. You can see diffuse thyroid tissue in the lung biopsy. So of all the metastatic lung diseases, if we have multiple nodules, then the three common things comes. One is kidney, one is thyroid, one is sarcoma of bone. And here it was thyroid. And thyroid USG was done, you can see, and then the thyroid scan was done. It was follicular carcinoma of thyroid presenting as miliary shadow. This is a small baby, 49-day-old girl. Poor feeding, refusal to suck, and excessive lethargy for 2 days, not passing urine for 16 hours. There was distress over the last 12 hours. So clinically, probable sepsis. There is no second thought about it. One must think of sepsis first, as this is the commonest cause. The distress increased, saturation was low, capillary refill was prolonged, there was grunting, there was retraction, liver was 2 centimeter. At this age, it's okay. Heart rate, there was tachycardia, weak femoral pulses. CBG was done, obviously it was more than 200. So with this picture, cefotaxime was started, catheter was put, urine output was low, and you can see there was severe acidosis in the CBG that was done. And the chest X-ray, you can see it's an ARDS-like picture. So after 1 hour, the saturation was falling. There was altered respiratory pattern, so child had to be intubated, ventilated in pressure control, and on ventilator the child was stable. But you see the blood counts where it was coming. WBC was 16,000, hemoglobin was 9.6. With such a severe picture, the CRP was negative, urea was slightly raised. So we were thinking of other causes. And even after 4 hours, BP was falling and perfusion was bad, so furosemide and other supportive treatment were continued. So echocardiography was done as part of other investigation. It was left atrium and ventricle dilated, so it was severe systolic dysfunction with ejection fraction 20%, and moderate MR was also there. So something was there. Now ECG was taken and it was L-kappa. L-kappa can often present as sepsis in a very small child. So if we have any doubt, better to do a ECG, because that's not that difficult to do. Better to do an ECG, because L-kappa, if not treated, it may be lethal and the treatment has to be specific. So L-kappa was diagnosed. 5-year-old girl, fever with cough for 2 weeks. On 5th day, the child visited a physician. Oral comoxiclav was given, not responded. Fever continued, admitted local hospital. For fever, the hemoglobin was 10, WBC 23,000 with neutrophilic, mainly platelets was nearly 4 lakhs and CRP was raised 150. And this was the chest X-ray. Again, you can see there is definite opacity in the lower zone. So initially, ceftriaxone vancomycin was started in the hospital, not responded after 4 days. Blood picture was similar. Gastric lavage, AFB was negative. USG was only minimal bilateral pleural effusion. Fever continued, so they upgraded it to meropenem and vancomycin. Now, the CT was taken. As you can see, there is a diffuse patchy lesions in both the lung fields. At this point of time, the parents thought it was very trivial. They revealed that the child had suffered from intermittent painful nodular skin lesions in both legs over the 3 months, and this picture mother had taken in her mobile and she shared with us. And there were 2 episodes of blood streaked sputum also during this total duration of illness. So what were the points to ponder? High-grade fever not responding to broad-spectrum antibiotics, worsening respiratory status, patchy opacities in HRCT, 2 episodes of hemoptysis with skin lesions and raised inflammatory markers. So probably we are dealing with a non-infectious fever where there is simultaneous lung and skin involvement. So obviously the ANA, Pianka, Seanka was done, it was negative. Bronchoscopy was done. Bronchoalveolar lavage was done. There was only mixed inflammatory cells. Only the skin biopsy clinched the diagnosis of vasculitis. It was deep dermis blood vessels with neutrophilic infiltrates and nuclear debris. So it was a vasculitis. So this case was anchor negative small vessel systemic vasculitis, presenting typically as an infective cause. 3.5-year-old boy, high grade fever 8 days, right ear discharge 5 days, pain and swelling in the right knee for 3 days, severe pain restriction. Now, fever, ear discharge with joint involvement, definitely we have to think beyond infection, but though infection comes as the first cause. Again, past episodes, 3 times hospital admission, query septic arthritis, treated with antibiotics. There were pneumonia also. You can see the different x-rays showing pneumonias from previous admission. This time hemoglobin 8.5, WBC 19,000, platelet raised. Again, ANA negative, and when immunoglobulin status was done, all were low. So this was primary B-cell immunodeficiency with presenting as septic arthritis. 2.5-month-old baby, restrictive movement of right upper limb, no history of trauma, extremely irritable, WBC 13,000, platelet raised 5,80,000, ESR raised, CRP 60, blood culture sterile. Is it septic arthritis? The doubt should always be there. But here you see there is thickening of the right scapular spine. And MRI was done, you can see the diffuse thickening of the cortex. So this is a Caffey's disease. So that may often mimic a septic arthritis. A 6-year-old girl came with cervical lymphadenitis with fever, malaise, and swelling over the left side of the neck. This was the typical swelling with signs of inflammation. Initially, cephalexin was prescribed by a GP, and after 2 days, no improvement. WBC was 21,000, neutrophil 44, platelet was 4,60,000, throat swab was group A strepto, so the GP changed to co-amoxiclav. Then the child was admitted because there was severe neck pain and the child was refusing to move the neck. Always one must think of, when the child is presenting with a neck pain, retropharyngeal abscess. So MRI was done just to rule out retropharyngeal abscess, and it showed retropharyngeal phlegm. Now, after 2 days, again no improvement. Co-amoxiclav was stopped because the child developed rash, thinking it's an allergy. Meropenem was started. Scrub typhus is a very common condition that we are often encountering with varied presentation, but again it was negative. Then this child developed these typical features, the red eyes, you can see the lip, the tongue, the nails, the chromonychia. This is not mehendi, but this is chromonychia actually, and the rash. So this was a case of Kawasaki disease. Now echocardiography was done and it was proven, IVIG was started and low dose aspirin, and the child recovered. Another child, 1-year-old girl with low grade fever for 5 days, cough and cold. This child had also a swelling over the anterior part of the neck. You can see erythematous, and it was very tender. So initially it was thought to be a cellulitis. So ceftriaxone and flucloxacillin started. Next day the child developed stridor. So dexamethasone was added and the child improved. MRI neck revealed edema of the anterior mediastinum, enlarged lymph nodes. It's an anterior mediastinitis, the MRI revealed. But still some doubt persisted. So ticoplanin was added to cover MRSA because it was an anterior mediastinitis. Fever subsided, WBC CRP decreased, but fever recurred after 2 days. Now the WBC is high, neutrophil high, platelet is 6 lakhs. So what are we dealing with? Now platelet count persistently increased. At this point of time, we are often Kawasaki minded. So echo was also done and it showed LAD dilatation, and at this point there was inflammation at the site of BCG also, and so it was a case of atypical Kawasaki disease, required IVIG, infliximab also low molecular weight heparin. After 2 weeks the child stabilized, but the learning is clinical symptoms of atypical KD are often diverse. Though this child presented with cellulitis of neck and anterior mediastinitis, but ultimately it turned out to be KD and responded well. To come to another spectrum, another commoner scenario that we may say often we encounter, 9-year-old boy, intermittent fever 2 weeks, high grade last 1 week. Initially the child was on homeopathic medicine, then admitted with mild pallor, hepatomegaly, splenomegaly. Hemoglobin was low, total count low. One SGPT done was 80, slightly raised. Outside, Vidal was 1 in 160. On admission, blood culture was sent. Ceftriaxone was started. Child showed improvement. So it was clinical typhoid. though backtech showed no growth, but after 4 days, the child deteriorated, became very toxic, febrile. Meropenem was started in place of ceftriaxone due to fever, thinking it might be MDR typhoid, but the child developed such features, such rash, pallor, icterus, mottled skin, hemorrhagic rashes, distended abdomen. So further investigation, obvious line, ferritin raised, triglyceride raised, you can see FDP raised in the X-ray, the diffuse patchy opacity, and this is bone marrow picture is of not this child, but just to illustrate it, typical bone marrow picture of hypocellular marrow with this increased plasma cell hemophagocytosis. So this was HLH. Probably this is a rather more common situation that we encountered in our practice. So I just wanted to present a spectrum of infection mimics with some cases. There may be clinical mimics, like most common are the fever. And the fever other than infections may be due to metabolic, maybe due to hematologic, malignancy, connective tissue disorders and others. And often with some systemic features the child may present, like joint pain or the cervical nodes that I presented. These are the clinical mimics. Of course, lab mimics, sometimes the counts and the inflammatory markers may be very raised, but that's due to non-infectious causes. And of course, the radiologic mimics that most of the cases that I presented. So whenever we see a case, think of an infection, we must think that mind is like a parachute. It works only when it's open. Thank you so much.